is going well. More than 170 registrations are there and is being liked by the audience very much. And today we are having the last session with two eminent speakers will be speaking on different aspects. And before we go for the scientific agenda, I will request Dr. K. Parikh sir, our the moral is the person who always boost our morale to continue these CMEs and inspire us for all these academic activities. Dr. Parikh sir, will you like to bless us with few words?
Thank you, dear. Thank you so much, Prakash ji. Welcome, friends. At the outset, I take privilege to welcome and extend sincere thanks to our two great visionary leaders, visionary as well as dynamic leaders. Our National President of API, Dr. Girish Mathur, and Dr. Jyotirmay Paul, Dean ICP and President-elect, for their excellent initiation on certificate courses on obesity. Thank you very much, sir, to grace this occasion.
Thank you.
This is the last module on obesity, and all these modules on obesity has enriched all of us to a great extent. So the man behind these obesity certificate courses is none other than Dr. Prakash Keswani, whose great efforts made this program so successful, attended by so many thousands of, I mean, if you calculate all these programs, more than 1,000 doctors have attended this program. So I welcome Dr. Prakash Keswani and extend my sincere thanks for this academic program. Today, we have got two eminent, as Dr. Prakash says, two eminent endocrinologists to enrich all of us on management of obesity. Dr. K V S Harikumar, endocrinologist of great repute, and a very simple person, very humble person. Then Dr. Ajay Shah, senior endocrinologist of Jaipur, one of us. Thank you, both of you, sir, for sparing your valuable time for the certificate courses on obesity CME program. I also welcome all my friends and delegates who are attending today's program. Without them, it would have not been possible to have such a successful program on obesity. So thank you very much, Prakash ji, and
thank you, sir.
Thank you very much for giving this opportunity to interact with so many leaders and legends of API. Thank you, dear.
Thank you, sir, for your kind words. Now I will request our dynamic president of API, who has done many of the wonderful things in his tenure, including websites, so many initiatives for the public awareness of various different diseases. And he is also the man behind starting this program and is managing this program for all the scientific logistics and all these things. I request Dr. Girish Mathur, sir, please bless with the few words.
Thank you, Prakash ji. Honorable Dr. K. Parikh, sir, our mentor and guide. Dr. Prakash Keswani, the man behind this program. Esteemed faculty of today's afternoon, Dr. K V S Harikumar and Dr. Ajay Shah, Dr. Nandini, Joint Secretary to Dean, Indian College of Physicians. Dear friends, we are entering into the last leg of the fantastic academic journey of ICP certificate course on obesity. Truly, it was a wonderful experience. And this certificate course was appreciated widely. So far, 13 talks on different aspects of obesity were delivered by eminent speakers. I wish to thank all of them, Dr. Rakesh Sahai, Dr. Srinivas Murthy, Dr. S.K. Sharma, Dr. Anupam Prakash, Dr. G.D. Ramchandani, Dr. Nitin Kapoor, Dr. Soumitra Ghosh, Dr. Sanjay Badada, Dr. D.C. Sharma, Dr. Sanjay Saran, Dr. Sanjay Kalra, and Dr. Sailesh Loda for their invaluable participation. I welcome today's speakers, Dr. K V S Harikumar from Hyderabad and Dr. Ajay Shah from Jaipur. I do not have enough words to express my appreciation and thanks to Dr. Prakash Keswani for organizing this academic event. His efforts were simply remarkable, and I'm sure the energy and enthusiasm which he has got, he is not going to take a break and will start some new course shortly.
Yes, sir.
My congratulations to Dr. Jyotirmay Paul, Dean ICP, for patronizing this program. I'm also grateful to our mentor, Dr. K.K. Parikh sir, for all his blessings. Lastly, I wish to express my thanks to all the participants whose presence made this program a success. Thank you so much, Prakash.
Thank you, sir. Thanks a lot for your kind words and all the words you have told me. Yes, we will start with the next program also very soon, as you have already asked me. And our certificates for our participants are also ready with Mr. Ajay Sharma. And without that, we will send them. And without wasting time, now we move towards the scientific agenda. Our first talk, today's session will be on the management of the obesity. And our first talk will be on the pharmacotherapy of the obesity. And for this, we have very eminent speaker with us, that is Dr. K V S Harikumar. He is the endocrine of national repute and is located at Hyderabad and working at Magna Endocrine Center in Fernandez Hospital. He has so many other qualities also, and is also looking after our endocrine society as at the post of secretary for so many years, and so meticulously he is doing that. I will request, and the other speaker is Dr. Ajay Shah. He is a good friend of ours, and he is the head of the endocrinology, SDMH Hospital, and he will be talking on the surgical management of obesity. I will request Dr. K V S Harikumar to now please start your deliberation.
Thank you, sir, for the kind words. Good
Thank
afternoon, everybody. And first of all, thanks to Dr. Keswani, Dr. Parikh, and Dr. Girish, and the entire team of API ICP for inviting me. This is actually one of the most, I would say, neglected, but most ripe topic, that is the pharmacotherapy of obesity. I hope I am audible and my slides are visible, sir.
Yes, yes, audible and visible both.
Perfect. So I will be covering this topic in the next 20 to 25 minutes under the following headings. Couple of slides about pathophysiology. I will not deal detail in that because I will only highlight something to do with the therapeutic perspective, the currently available drugs, and I'm sure most of you are hearing about the gut-based molecules and newer additions in the therapeutic areas of obesity. And I'm sure it is relevant for all practitioners. So you should be having some practical questions, how to start, how to end, all those things. So some questions I'll be dealing at the end. And there are no conflicts of interest in regarding to this talk. So that is my standard disclosure. The problem statement of obesity, we have just read the ICMR INDAP study, which was published a couple of weeks back in the Lancet. Almost 30% of people have obesity and 40% have abdominal obesity. So almost like every second person has obesity, even in the so-called developing nation as in India. So, I mean, if you look at the, say, Western data, it is almost like 75% of the population have obesity and we are at 50%, and we are fast trying to catch up, unfortunately, in some areas which we don't want to. If you look at the pathophysiology of energy balance, it is a simplistic understanding is actually a calorie-based model where you just think that you're consuming in excess and that excess is getting deposited and that is going to add up to the obesity. That's like a very, I would say, the naive way of telling that it is like you're gaining because you're eating. So that was possibly the thought process till many decades ago. But now you have more players involved in this actually. That is, what does the relation between the gut, the fat, and the brain? And there are too many players involved in this to actually determine why you are gaining weight. So if you look at a simplistic model, maybe you just have to have a reduction in the calorie consumption, you will lose weight. That's okay, understandable. But when you look at the other things which involved as far as the complex model, you have the signals coming from the fat, signals coming from the peripheral tissues. And all these things are what is known as the homeostatic eating. But after homeostatic eating, you have something which is the centrally derived one. You eat for your pleasure. That is the hedonic eating, where you want to enjoy the feeling of eating. So that is one. And overriding all these things is the executive decisions to eat. Despite not being hungry, despite not having pleasure, there may be situations where you just have to gulp certain things. So that is like your brain overrides all those things. So you have a plenty of players which control all these things, which have a role in playing why you are becoming obese. Why I have highlighted this, because most of the newer therapeutic drugs are coming into such of these areas. So you should be having some idea about this. The hormones and peptides involved plenty of hormones in the central as well as the peripheral areas. Only important thing, the ghrelin is the only appetite stimulating hormone from the periphery. For the control of appetite, you have plenty of the things, whereas central, you have equal number of orexigenic and anorexigenic ones. The fat tissue, you have the leptin, which is going to give you the what you call the stores, which are there as far as the fat stores, which convey the message to the brain. When you look at the approach to the obesity, the simple lifestyle modification is the foundation of management. There is no doubt about it. That is the cornerstone. There is no doubt. And only failure of this will start with pharmacotherapy, and surgery is the last resort, because obviously most of them are irreversible. You will be hearing about surgery in the subsequent talk. Now, about the obesity drugs, I mean, almost a century back also, people thought that we should be having some drugs to lose weight. And most of these have been fraught with side effects. At irregular intervals, drugs have been coming, drugs have been going back. You can see the calendar that so many drugs have come in and so many drugs have gone out. So much so that lorcaserin, which was approved just possibly a decade back, is no more available because it's off because of its carcinogenic properties. So you have plenty of players who come out and who lose their potency. The currently available approved drugs for the long-term management are only limited to 4-5. One, obviously the GLP-1 receptor agonist. I'll spend some time subsequently also there, which has the central as well as the peripheral site of action. Now, why I have shown this is important, it acts at different sites of the brain. That is also important. It is not only at the hypothalamus it matters. It is at the brainstem, it is at the cortical level, it is at the limbic system. So there are plenty of systems where it acts. The centrally acting naltrexone and bupropion, again, it is only the centrally acting. Same with the phentermine and topiramate. Both have been approved, but not approved for use in India. That is also important to understand. Orlistat, it has no central mechanism. It is peripheral lipase inhibitor, so only GI mechanism. So it is, as of now, the only approved drug. If you are looking at in India, that is the only Orlistat. The newer molecule, the tirzepatide, that is the GIP and GLP-1 dual agonist, has again central as well as peripheral action, which potentiates each one and possibly is going to be some of the game changer in the near future as far as the management of obesity is concerned. But to make it simple, as of now, the approved drug in India is only Orlistat. Off-label use, you have plenty of other options available. But if you are looking at standalone pharmacotherapy, that is the only one. Now, what amount of weight loss you're going to get with each of these drugs also is important when you use them. Now, if you look at onto your left side, the Orlistat is to the tune of about 4 to 5% weight change over a period of 1 to 3 years. Now, you compare to your extreme right side, the tirzepatide of 15 mg weekly injection, it almost knocks off about 20% of weight loss. The 10 mg knocks off about 19.5 and 15 mg of 21%. The semaglutide, it is almost going to take off about 15% of the weight change. So you have the GLP-1 receptor analogs, which will take off almost to the tune of 15 to 20% of weight loss than when compared with the older generation molecules of about 5 to 7%. Liraglutide is approved as a anti-diabetic agent. In a higher dosages, it is approved as an anti-obesity agent, but again, not received the approval in India. And the same 3 mg dose is not available, but most of the people use it, dialing more number of dosages using the available. The semaglutide is the recent ones which is approved for the management of obesity. If you look at it, after 14, in the last decade, this was the only drug which was approved for the obesity. Setmelanotide is also an approved agent, but it is mostly relevant to a syndromic obesity. It is not approved as a generalized obesity. Tirzepatide is approved for diabetes, but not as an anti-obesity agent as yet. To look at what is the role of the setmelanotide, by and large, these are the PCSK mutations, leptin receptor mutations, or the POMC mutations. You have the syndromic obesity, mostly monogenic, and you have a significant improvement with the use of setmelanotide or a recombinant leptin in such setting. But as I said, since it's a pharmacotherapy of obesity, syndromic obesity also has some drugs available. And once you use this MC4 agonist, it has various central as well as peripheral actions right on the liver, adipose tissue, pancreas, and skeletal muscle, which will help in patients losing their excess weight. This is the STEP studies are the ones which actually look at the entire range of the semaglutide injectable 2.4 mg weekly. And you look at the amount of weight loss when compared with the placebo, it is almost 15 to 18% of weight loss in patients in different subset of groups, step 1, step 2, step 3, step 4, the different trials with different baseline indications. So on an average, you lose about 15 to 20% with the usage of this semaglutide. The GLP-1 analogs we all have been using for almost more than a decade in the management of diabetes. The benefits of GLP-1 we all know. The GIP, despite knowing very well that it's a almost like a co-secreted incretin along with the GLP-1, had I would say more of a different or maybe a equivocal results as far as the usage has been concerned. But now tirzepatide has shown that the GIP agonist also has got a significant role to play in improving the metabolic parameters, in improving the weight, having both central as well as peripheral action. So it actually potentiates the GLP-1, and you have both put together will give you a more benefit than when compared with the GLP-1 agonist alone. The SURPASS and SURMOUNT is the acronym for the all trials which have been using the tirzepatide. If you look at as far as the placebo controlled or in comparison with the active comparator, it is actually looking at the most of the people who have used tirzepatide have lost about again 13 to 20% of weight loss. The only SURPASS 2 was the trial which compared with an active comparator, that is the semaglutide, but only difference being the semaglutide in this trial, they have used as 1 mg per week, whereas here the standard dose as far as anti-obesity is concerned is 2.4 mg per week, whereas for the tirzepatide, it is about 15 mg per week. But nevertheless, it is almost showing the maximum benefit amongst the available GLP-1 RS. So the science has moved from the incretin, that is the standard GLP-1 analog, moved to twincretin, that is tirzepatide, which is already approved for a type 2 DM. And we are now shortly, there are trials phase 2 and phase 3 going on for the tricretin molecules, that is GLP-1, GIP, and glucagon analogs, which will again have most of the benefits what we have been talking about addressing the metabolic syndrome. So these are the newer drugs. If you look at it for the management of obesity, the Wegovy is the one which is the anti-obesity drug, whereas the same semaglutide is under a different name of Ozempic, which is for the anti-diabetic action. And tirzepatide is approved for diabetes, but not as on date approved. It has been put under fast track by FDA to get a approval. but average weight loss in the diabetic trials is almost to a tune of 22%. And as with any other GLP-1 molecule, the side effects pertains predominantly to the GI side effects. If the patients have been explained adequately and the patient has tolerated the initial 1-2 injections, definitely these are going to be significant molecules which will help in the management of obesity. Now, I'm sure you will listen more about the surgical procedures in the subsequent talk. But if you look at the surgical procedures, the standard sleeve gastrectomy is one of the, I would say, the commonest or possibly the easiest to do. And at the end of 1 year, you get about 25% weight loss, and Roux-en-Y, you get about 30%. Whereas here you have a drug which is going to give you almost about 25% weight loss with a non-invasive, reversible, and affordable or not, we don't know, but still it is going to be a drug which is going to give you almost same as what the surgical procedure offers. So the new drugs are actually filling the gap between the diet and bariatric surgery, which are going to be some of the good molecules in the fight against the obesity in maybe a decade, next decade or so. What is the current evidence which have shown to be the best as far as the trial data are concerned? Network meta-analysis published in Lancet last year, which looked at different active comparators. The size of the node represents the number of population and number of trials, the thickness of the bars. This is a conclusion in adults with overweight and obesity, phentermine, topiramate, and GLP-1 RA proved the best drugs in reducing weight. And of GLP-1 agonists, sema might be the most effective. They had comparison with sema also, and they had comparison with the liraglutide also. So this is the current position as far as what are the efficacious drugs and how best they work in patients with obesity. Now, this is what is available, including some of the GLP-1 analogs, but the buck doesn't stop here. There is plenty of research which is going in this field. Why I'll tell in subsequent 4-5 minutes. Issues remaining obesity initially was, it was not considered to be a disease, number one. And if it is not disease, there was no reason to treat actually. So the terminology itself, because it was more of a social term of being a obese and stigma associated with it. So last maybe 5-6 years, AS, European Association, all of them have coined this term, what is known as the ABCD. That is the adiposity-based chronic disease, because this has some roots in observing some patients who are metabolically obese but normal weight, and even in normal weight with unhealthy. So all those spectrum determine this. You should have, instead of a plain and simple BMI-based classification, you should have a ABCD classification, which will help in physicians determine whether the person is suffering with the disease of obesity and take a corrective action. Why no drugs? Obviously, options are very less, lack of knowledge, lack of familiarity with the drugs, and possibly some of them have a price barrier also to use. And most of the anti-obesity drugs have a checkered history. So you don't actually feel comfortable in using a molecule which is, you don't know the longevity of it and how long it is going to sustain. So if you look at the recent advances where more research is going on, the therapeutic approaches can be broadly classified, because this is how, if you consume, you absorb and then you expand, keeping the simple model and modifying the other areas also. There are 3 areas if you broadly classify. One is the reduced intake, second is the reduced absorption, and third is increased expenditure. So these are the 3 ways you can classify as to newer approaches. As I said, ghrelin is the only appetite stimulating hormone. So you have ghrelin antagonists being studied. All the gut-based hormones, you have most of the agonists being tried for all the hormones or peptide mediators. Ghrelin antagonist, I've already said, because the success lies in the gut, manipulating the gut hormones or gut peptides only. The microsomal triglyceride transfer protein inhibitors, which will prevent the absorption of the fat and possibly reduce the absorption. Some of the gut microbiota also have got a role to play, because especially animal studies have shown that the obese mice have a different bacterial flora than when compared with the lean mice. So transfer them to here, you're possibly losing weight. SGLT2 inhibitors, I'm sure most of you would have been heard plenty of times about this, but you do lose about 60 grams of glucose per day. So that is also one of the ways how you increase your expenditure. Brown adipose tissue is something which is very important to have and possibly not much there as an adult, because it actually has more of thermogenesis rather than calorie production or storage. So browning actually helps. And most of the times when you do exercise, actually the irisin is the key hormone which converts the brown adipose tissue to the white adipose tissue. So you have now people developing the irisin agonists. Without doing the exercise, you might possibly get the benefit of getting your fat into a brown fat rather than a white fat. The rimonabant story we all have seen and heard and possibly used, some of us, because of the endocannabinoid system activation. The only problem being it was activating the central also. The peripheral activation actually helps, but you don't want the central side effect. So that is where the problem lies with the rimonabant. So now you have a peripheral cannabinoid blockers which don't have the central side effects. So possibly they also will come into market in few years ahead. Another important hormone is actually the cortisol. The inactive cortisol is converted to active cortisol at the tissue by 11 beta HSD1. Now you have 11 beta HSD1 inhibitors which are being developed to reduce the tissue levels of cortisol, which will again reduce your obesity, diabetes, and all those things. FGF21 gene is again tried in the animal models, which helps in conversion of brown to white to brown adipose tissue, central as well as peripheral actions, plenty of those things. So you have a different, different mechanisms of drugs which have been tried despite having, say, I would say at least a handful of options, but you have plenty of other options being developed. You have reduced intake. These are the things which are there. The amylin analogs, the cagrisima, that is the amylin and GLP-1 analogs are also the dual agonists also are being tried. Reduced absorption, you have fecal transplant, postbiotics, bile acid metabolites, and increased expenditure using all these drugs. These are the new groups which are being tried for obesity. As I said, there's plenty of research going on in this area, because if you find a good molecule which is going to lose weight, at least 70 to 80% of world population are the potential candidates for this drug. So it is going to be a blockbuster. So you have peripheral as well as central mechanisms, actions, and amount of research which is going on in this area is tremendous. But word of caution, yeah, the important one is actually the approval and withdrawal. If you look at it, most of the drugs have come and have gone back within few years. So that is important to understand that it is, they should have sustained effect. How to select a drug, it is important to understand. If depending on the indications based on BMI and age, if you have less than 65 without comorbidities, you can use any of the approved drugs. More than 65, possibly the GLP-1, the Lira and Sema only, Phenterm and Topiramate to some extent. If somebody has got history of medullary thyroid cancer or pancreatitis, GLP-1s cannot be used. So there you can use the other ones. Somebody who has got a depression, again, will give you that central benefit also. But most of the other spectrum, you would use GLP-1 RS as the first choice of obesity. And important other thing is, when you're selecting your antihypertensives, when you're selecting antidepressants, look at some of the weight neutral effects. Anti-diabetics, most of you are aware, but say beta blockers tend to gain weight. So you can use ACE inhibitors or ARB, something like that, when you're choosing the other drugs also in these patients. Non-responders, you should give a drug at least for 3 months, and if you don't lose within less than 5% of weight, they classify them as non-responders, and you should choose a alternative option. Trying a lot but not losing, body also tries to change and has a different set point, and hormonal changes also, all those things differ as you try to lose and as you are losing also. So the efforts have to be multiplied accordingly. And how much of weight loss is what patients commonly ask. Even if you lose 5%, the DPP trial has shown that you can prevent diabetes. If you lose 10%, you can convert patient from metabolically unhealthy obesity to metabolically healthy obesity. And 20% they'll convert to normal. So important to explain, go slow and gradual. The effort is phenomenal and the result may come from any direction in the patients with obesity, but you should have persisting effort. And actually the obesity is the actual pandemic of this century. And energy balance is not very simple. It is appears simple, but you have plenty of central players also in it. Multiple drivers of eating and calorie surplus are the key problems. And you have maintenance of weight loss due to metabolic adaptation is very challenging. As of now, gut-based molecules have shown good results, but comprehensive management with continuous education is important, and never stigmatize a patient of obesity. That is most important. Consider that it as a disease, explain them and partner them as far as addressing that. They will be happy in losing their weight. I've finished here. Thanks for the opportunity.
Thank you, Dr. Harikumar, for your nice talk and covering all the aspects of drug management, starting from 1990, the use of amphetamine, which was started later on, phentermine, and all these were introduced. Many of these were again withdrawn from the market because of some of the other side effects. What do you think, Dr. Harikumar? What is the cause that many of the patients are not convinced for the treatment of obesity? And if they are convinced, the results are not so good in majority of the patients.
Okay. The issue is why it is not being considered is, it is never considered as a disease per se, first point. So if you consider that obesity is like patient because of obesity developed hypertension, developed diabetes, developed dyslipidemia, you have no inhibition in treating any of those things. But nobody is comfortable treating the root cause of it. That is actually the obesity. And the second reason is you don't have actually options available to treat. So obviously, if you, it's like, I mean, some of the neurological disorders where you discuss endless, but you have actually no therapeutic options available. So you actually should have therapy. Then only the disease also will take a importance or a precedence in addressing that. Patients also feel that it is their right to be of so-and-so BMI, which they consider that if you're losing, and there will be so much of, I would say, peer group pressure or maybe family pressure that why you're looking like this, why, what happened to you, all those things. So whenever somebody is even coming back to a normal BMI, they are not ready to accept that from within or from outside. So obesity was never considered that as a disease. So that is where there is a reluctance in as far as the therapeutic options considered.
I think the most important thing on our part is to make all public aware of the obesity, because they do not know that they are obese. So when a patient comes to us who looks obese, we must get his height and weight, and accordingly just in height in centimeter, and then weight. If we divide by 100, height in centimeter divided by 100, the actual almost approximately ideal weight will be there. So we must aware these patients or public that obesity is the reason for so many metabolic diseases, which because they don't understand that they are obese. First, we have to make them clear that you are obese. And it can be done only by awareing people, taking their height, taking their weight, and asking them that now you have got 20 kg more weight, so you have to reduce 20 kg. It is very difficult for to ask them for physical activity, but we have to tell them, and again, motivation for lifestyle modification one can follow. So I think awareness is the most important thing about obesity. Thank
Males
you.
at all do not think that they are obese.
Yes.
Some females And that is also because of the cosmetic reasons. They think they should go for the weight loss.
Right.
And Dr. Harikumar, we have already stayed for around 18 or 20 years with us. What is your take on this drug? Is it so effective or any side effect for which it is not used?
Efficacy wise, actually, for the cost of it, I mean, current latest meta-analysis of Lancet actually said that it is as good as a placebo. I wouldn't say it is, but the article says so. It's about you have lost about 3.9 kgs over a 1 year usage, continuous usage of 120 milligrams thrice daily. Now, the cost, if you look at it, cost benefit ratio, 3 kgs over 1 year for a drug equivalent to almost close to 100 rupees a day, which is actually not worth it. I mean, if you put a intense lifestyle modification, you would obviously, the look ahead study is there, which actually looked at, and possibly you can have a, I mean, daily coach who is going to come and explain to you, and possibly you will get a more benefit. 10% weight loss will easily become if somebody is training you 24/7. So
Yeah.
that is why Orlistat, despite being in the market for so long, did not go out, and it is actually in the OTC product of 60 milligrams. But the efficacy is very minuscule. I mean, practically, I've never used it.
Yes. And what do you think about these newer drugs, GLP-1 analogs, which are not clearly available for the obese? And again, the cost factor is too big for our Indian population. So do you think that they will be effective and will come out as a good anti-obesity drugs?
So, in even our subset, the GLP-1s are going to be a good anti-obesity agents. In people whom we are using like those obese type 2s, we have been observing significant, at least 10 to 15% of weight loss with the current either oral or injectable preparation. The only issue being the cost. The second most important thing is the GI side effects. If somebody is able to tolerate the initial side effect, and there are almost like every third person will have a significant nausea, significant vomiting that they are unable to tolerate. But in some who have been able to tolerate otherwise, they are going to offer you a good opportunity as far as the weight loss is concerned. And they will be there in the, because actually if you look at it, it is predominantly the gut-based molecules only have sustained. There is nothing else which has sustained. All the research is also directed at that, and whatever drug you have, either central and peripheral, the only GLP-1 based molecule. So they will be there. And in the current, almost about now from the exenatide days, we are almost 15 years now. So, I mean, unlikely that there is any major side effect which will come into.
So they will be proved as a good, effective anti-obesity drugs in future, right?
Absolutely, yes.
Yes, Parikh sir, do you want to say something? Unmute yourself, Dr.
Sir,
Parikh.
please unmute. Sir, you're muted.
Parikh sir, unmute yourself.
Yes, I mean GLP-1 antagonists in non-diabetic obese person. Do you have some idea that it may cause hypoglycemia?
Sir, no, sir. They don't.
No.
They won't cause hypoglycemia. Absolutely no.
No,
the glucose lowering action is a glucose dependent insulin release. So the moment you have a lower glucose, there is no hypoglycemia.
Right, right. Thank you.
Thank you, Dr. Harikumar. You had nice talk, covering so many good things, new things, which were new for us also. Now we will move towards our second talk of the day, that is surgical management of the obesity. For this, I invite Dr. Ajay Shah, who is the leading endocrinologist at Jaipur, for giving insight about the surgical management of obesity. Dr. Ajay Shah, will you start please your lecture?
Thank you. Good afternoon, respected Parikh sir, Vishwapur sir, Dr. Keswani, both as my teacher and now as a colleague. Dr. Harikumar, and welcome delegates. Let me first share my slides. Okay, slides have come up.
Yes, they are good.
Okay, so we've dealt with epidemiology, We've dealt with pathogenesis, and this is the last leg, I was told. Pharmacotherapy has been done, and my job is to discuss the surgical treatment of obesity. I know this is an audience almost nearly exclusive of physicians, and how much interest they are in a surgical topic remains to be seen. But just the fact that there is a sizable chunk of obese patients who would require surgical treatment or who are deemed to be good surgical treatments. So Dr. Harikumar already mentioned about the secular trends of the pharmacotherapy. Similar is the secular trends for surgical treatment of obesity, and I will briefly try to touch some of them. So why surgery? So as Dr. Harikumar has mentioned, up till now, diet, exercise, and even pharmacotherapy at best are as good as placebos. Not more than 5% of weight loss is achieved. And what is achieved probably is regained. The cost is the cost effectiveness. And importantly, the pharmacotherapeutic agents have not stood the test of time. So durability of the pharmacotherapy and the lifestyle modification measures are at best very modest. So surgery is still an accepted and an effective, I would say the most effective approach. It also addresses the comorbid conditions. In fact, sometimes remission is achieved, and the remission is achieved prior to weight loss, before the patient is discharged. That's the beauty of it. Life expectancy is increased, and surgical risks, just like any other surgery, are very much acceptable. So the indications of bariatric surgery. So if you look at the international or the Western guidelines, they say that any person who is morbidly obese is a good candidate for bariatric surgery, which means BMI of more than 40 or BMI of 35 with 2 comorbid conditions, and sometimes if there is a failed pharmacotherapy. However, because the classification of Asian and Pacific Islanders is a little bit different, and so the indications for bariatric surgery for populations like India, the BMI is 35 or more, or 32 with comorbid conditions. Now, these are a large number of patients, even in our BMI 32 with comorbid conditions. Large number of patients are deemed suitable for bariatric surgery. So who is a surgical candidate? For Asians, let me revise you, BMI of 32 with 2 or more comorbid conditions are justified to undergo a bariatric procedure. So having talked about the indications, there is a social aspect to the bariatric surgery. And this pertains to the understanding of the procedure, which needs to be explained. And if the patient is accepting this procedure, then he is a good candidate to undergo the bariatric surgery. Of course, the obesity needs to be primary, and there should be no secondary causes of obesity. Importantly, Cushing syndrome or syndromic obesity are the ones that we are on a lookout, on these morbidly obese patients. Sometimes you can have them. The most important point against surgery is that the patient should have a stable mindset. The presence of a psychiatric condition, including the history of substance abuse, puts the patient in a relative category of relative indication for bariatric surgery. And the patient should still accept that, unlike most surgical procedures, which would mean do the surgery and close the chapter, is not that. Despite having undergone the surgery, the patient is still willing to undergo and continue with the lifestyle changes and should be able to follow up with the bariatric team. Amongst the contraindications for the surgery, the severity of a coexisting medical disease like coronary artery disease or severe obstructive sleep apnea. But most important would be that the patient should have a stable mindset. There has to be a no psychiatric disease, including history of substance abuse. They should not be there. There should be adequate comprehension of the patient so that he can adhere to the treatment and follow the instructions of the bariatric team. Patients who have a limited lifespan because of coexisting either malignancies or CLD, because these are closely associated with obesity, they needs to be excluded from the bariatric program. So the preoperative and the prophylactic medications are that if the patient has a comorbid conditions, these needs to be continued. For those patients who are diabetic patients, the insulin needs to be given and the oral hypoglycemic agents have to be stopped. And here I would like to state that the single most important prophylactic medication for a patient undergoing bariatric surgery is the prophylaxis against the deep vein thrombosis. And this is because the obese patient himself, because of the obesity, is at a high risk of DVT, and the laparoscopic procedure entails a higher risk of deep vein thrombosis, and therefore, at least we ensure in our patients deep vein prophylaxis either through intermittent compression pumps or enoxaparin in our bariatric program. What are the surgical risks involved in a bariatric procedure? Of course, just like any other surgical procedure, a procedural death is a real risk. In real world and in practice, the mortality rates are up to 1%. That means patients dying within 30 days of the procedure is called a procedural death. So that is about 1%. But if the surgery or the procedure is done in a high volume center by a skilled team, then this mortality figure is down to 0.3 to 0.5% in various studies. Because the surgery involves lots of malabsorption, one of the long-term risks to the patient is malnutrition, not only of the proteins, but also of various vitamins and various minerals. And they should be, the patient, we have to be on a lookout for these deficiencies occurring. And it's my personal experience that most morbidly obese patients are already deficient in their vitamins and minerals, even just prior to their surgery, during their workup to the procedure. their malnutrition is uncovered. And these are the patients we have to be really careful and counsel about them. Peritonitis, because the procedure site involves the peritoneum. And then there are some nagging side effects, dumping syndrome. Sometimes it can have a serious connotation like hypoglycemia, which may be occurring with certain procedures, diarrhea, problems because of malnutrition, and sometimes pain. So these are some of the risks that are there with bariatric surgery, which need to be explained prior to the procedure. At this point of time, I would like to state that there are various procedures for weight loss. But amongst one of them is the liposuction, and it involves removal of fat, mainly from the abdomen, chest, and the back, although a more localized form of liposuction is available for the arms or for the buttocks. But these are not classified as bariatric procedures for the simple reason that despite weight loss, the metabolic parameters do not improve with liposuctioning, and therefore my talk will not include liposuctioning as a procedure for weight loss. When I completed my DM, most procedures for bariatric surgery were done as an open surgery. And just like the evolution of pharmacotherapeutic drugs, there has been an evolution and a refinement in surgeries for bariatric procedures, and no longer, even in our country, are open procedures recommended or being done for bariatric procedures. Most procedures nowadays are done through a laparoscopic way, and I'll deal. So currently, most surgeons are confident with laparoscopic procedures, although just like evolution of any other procedure, a non-invasive way is the way forward. And sometimes some procedures have been clearly usurped by the endoscopic procedures, which we will discuss, so that we have moved from open era to currently laparoscopic era, but probably we will be seeing the endoscopic procedures being completely taken over by the laparoscopic procedures. So we can classify the bariatric procedures either as restrictive procedures, just like the way Dr. Harikumar had classified, try to reduce the intake, restrictive procedures, or you reduce the expense, the malabsorptive procedures, and a combination of them. So the restrictive procedures involve creation of a small gastric pouch. It produces early satiety, and therefore reduced caloric intake goes through the gut and less amount of calories are absorbed. The malabsorptive procedures would mean that the more the anatomy of the intestine or the gut is modified, mainly the small intestine is reconstructed so that much of the food is actually not absorbed or bypassed, and the caloric intake is actually not done. Having said that, there is more to what appears on board. And the reason is, as Dr. K V Harikumar had also mentioned, there are more players. There is a foregut hypothesis, which means that ghrelin, which even Dr. K V Harikumar alluded to in his talk as the appetite stimulant, which is secreted from the stomach. If you try to avoid that, that would be one of the ways of reducing the calories or I would say a surgical way of reducing. That is one of the ways. And the hindgut hypothesis, which apart from the gut microbiome, all that, it mainly focuses on the alteration in the gut hormonal system, particularly the incretin hormone, because of the early delivery of the nutrients into the distal intestine, that malabsorption occurs and that the weight loss. So these are the various mechanisms why bariatric procedures cause weight loss, and why it is important to know these factors is because we have witnessed a remission of diabetes before the weight loss occurs. Before the patient is discharged, the diabetes goes away. It cannot be attributed to the simple anatomical variation that has been done to the patient. Certainly, it has to be the homeostasis, hormonal milieu that is disturbed, which causes this. So the various restrictive procedures are the intragastric balloon, the vertical banded gastroplasty, the adjustable gastric band, and the sleeve gastrectomy. The malabsorptive procedures are the biliopancreatic diversion BPD, sometimes combined with the duodenal switch called the DS, and a mixed procedure which is called as Roux-en-Y gastric bypass. So a little bit running through the restrictive procedures. I know we all are physicians. I'll not bore you with the procedures. So one of the procedures is the intragastric balloon. So a balloon is inserted endoscopically and it stays in the stomach, and the timing is for 6 months. That's the upper limit. Although newer balloons like the Opitz balloon may be kept for up to 12 months, up to an year. And this procedure entails some degree of weight loss and can be used as a start of the bariatric procedure before a more definitive procedure is being done. It's a simple endoscopic method. So even a gastroenterologist can do it. So procedures like Roux-en-Y gastric bypass are more skill demanding and require an infrastructure. To begin with, one can start with a gastric balloon. The second restrictive procedure is the adjustable gastric banding. It looks very easy. It's non-invasive. Just a band is actually placed right at the fundus. So the pouch is reduced. And this can be adjusted depending upon the meal intake and the amount of weight loss that is desired. The adjustment can be made through a port that is on the abdominal wall, but this is not a very effective way of weight loss, and the patient needs to follow with the bariatric surgeons. Less effective, intense follow-up is required. Not very popular in India as a whole, but nevertheless quite acceptable to the patient because there is no surgery actually being done. But the most common procedure is the sleeve gastrectomy. And you can have a vertical gastrectomy done so that the whole size of the stomach is just 1/5 of the current size. And why a vertical gastrectomy is preferred is because on the greater curvature of the stomach is the site of ghrelin production, and that you try to exclude with it. So sleeve gastrectomy has come up in a recent way. It's an easy procedure for a newly trained bariatric surgeon. Not great amount of skill is being required. It is being done laparoscopically, but nowadays, for last couple of years, even endoscopic sleeve gastrectomies people have started doing, even in our country. It is acceptable to the patient because there is no scar. Some of the celebrities do perform, have already undergone endoscopic sleeve gastrectomy. Let's not discuss about the procedure. So sleeve gastrectomy can be used as an initial bariatric procedure, as an initial state procedure for a more definitive procedure at a later date if weight regain occurs. And we come to the malabsorptive procedures, and the most common malabsorptive procedures is the biliopancreatic diversion, BPD, where unlike the sleeve gastrectomy, it's an old procedure. And here, instead of a vertical gastrectomy, a horizontal gastrectomy is produced, which is not a very good idea, fraught with many complications, and therefore quite unpopular, both with the surgeons and with the patients. Sometimes, however, it's a suitable procedure for super obese, sometimes BMI more than 50 or 60, and you can combine this procedure with a duodenal switch. You can also use this procedure after a failed sleeve gastrectomy, and sometimes as a revisional procedure for bariatric surgery. But one of the commonest procedure is the Roux-en-Y gastric bypass. Now, this is a technically demanding procedure, particularly if done in a laparoscopic way, which is easy for the patient, but you require certain degree of skill, and there is a learning curve to do this procedure for a bariatric surgeon to achieve optimal results. And what is entailed in this procedure is a very small creation of a vertical gastric pouch, which is combined with a bypass, which comes from the jejunum. So you can have a gastric bypass coming up, and we'll discuss the result. Although this procedure also entails lots of side effects, and therefore what is upcoming in the laparoscopic bariatric procedure is what is called as one anastomosis gastric bypass, or commonly it is called as mini gastric bypass. So let's discuss the results. So the adjustable gastric banding results in about 30 to 40% of weight loss. Mind you, compare this with pharmacotherapy, 5 to 15%. And here you are achieving something like 35 to 40% weight loss. Remission of diabetes, 50%. So these are some of the statistics for the band, lowest complication rates, but actually it requires frequent follow-up with the bariatric surgeon. Therefore, attrition rates are quite high with the band. Sleeve gastrectomy is quite common. It is being increasingly done on an increasingly large population of bariatric surgeons because it's easy to do laparoscopically, although it is now being done even through endoscopic routes. Weight loss is excess of 50%, the baseline weight loss. The remission rates of diabetes are over 60%. And this procedure is now gained like anything over the last decade or so. Roux-en-Y is the most preferred procedure. Weight loss is about 80% from the baseline weight loss. The remission rates of diabetes is more than 80%, although it entails because so much of anatomy is being done in this procedure, acceptability and consequence is needs to be kept in mind, quite malabsorptive with lots of malnutrition being shown up. So Roux-en-Y, and amongst the at the center where I work, we've done about more than 800 bariatric procedures. The commonest was the Roux-en-Y, something like 500 or so, mainly because we stressed only those patients who had diabetes, and remission of diabetes was uppermost in our mind, apart from the weight loss. Although sleeve gastrectomy is fast catching up, and about 100 procedures of sleeve gastrectomy at our center have been done. So for a procedure like Roux-en-Y, we've lost, the patient loses about 65 to 70% weight loss, and remission rates of diabetes are more than 80%. I have limited my slide talk to diabetes because this is the focus of interest to most of the audience. Although there are improvements in rates of hypertension and dyslipidemia as well. So the rates I have not shown. So there are some immediate problems and problems which are common to all bariatric procedures. This being because it's an cut and join clumping procedures, there could be anastomotic leak. We are using staples rather than manual work. The staples have improved, although there could still be a leak in the staple line as well. And I've already mentioned one of the dreaded complications is the DVT and the embolization consequent to it. Most common cause of mortality post-operative is the DVT. Most obese patients have gallstones. We try to remove the gallstone right at the bariatric procedure itself, because weight loss, not only because of the bariatric procedure, but even through lifestyle modification and even pharmacotherapy, development of polylithysis as high as 30 to 40% is noted as a side effect of weight loss, which means if polylithysis is there before the procedure, try to counsel the patient for removal of the gallbladder itself in the same procedure. This is important because gallbladder is a cancer which is diagnosed late. Polylithysis is one of the implicated causes, and it happens more in obese patients. So you have to be on a lookout, and needs to be done that. And I've already mentioned the other complication being the stomal ulceration, which was very common, which is very common, in fact, because in the horizontal gastrectomy procedures, where the pouch is not all that small and the intestine is there, there could be an stomal ulceration. But supposing you have a vertical gastric pouch no larger than 50 to 60 ml, which is vertical, at least 5 centimeters in length, you reduce the risk of stomal ulceration. But just the fact that it is one of the complications. Dumping syndrome you can find, particularly with the bypass procedures. With one anastomotic or the mini bypass procedure, the dumping syndrome has reduced. Although we've even seen with one anastomotic or single anastomotic mini gastric bypass procedures, dumping syndrome being there. And of course, there are lots of side effects, nausea, anorexia, including constipation. Patient doesn't eat. If he doesn't put from the top, what will come out from the bottom. And this is the proposed follow-up by the Endocrine Society of US for bariatric procedures. We need to look at chemistry, need to look at the hemogram, certainly be on lookout for minerals and vitamin deficiencies, notably calcium and vitamin B12, and therefore even a BMD is included in the list for those patients who have undergone bariatric surgery. Females undergo it, and they anyway would require BMD anyway. So we are following this protocol for our patients at our center. So common nutritive problems post-operative on a long-term basis are the vitamin, protein, and mineral deficiencies, and we need to replenish them. Iron deficiency, calcium deficiency, all the vitamins, just need to give them. And here I would like to tell you, because these patients have undergone severe anatomic modifications in their system, do not hesitate to use parenteral, either vitamins or even minerals for that matter. Parenteral iron, parenteral vitamin D, you need to resort that, because these are now malabsorbing patients. Oral replenishment may not suffice. So these are some of the postoperative long-term complications and effects because of long-term complications. And one of the concerns why patients will return to use is the weight gain. Normally, it happens 2 years after the procedure. Weight gain is seen because of number of reasons, some of which I've already mentioned. The commonest of which is inadequate counseling. You need to stress the patient that although surgery had been done, still lifestyle diet remains to be followed up. There are various diet regimens for various procedures. I think I forgot to mention that which procedure needs to be done on one patient depends upon the degree of obesity. Just like we select any other drug for a suitable patient, we need to choose the procedure. Apart from the patient factors, there has to be the surgeon factors. If you have a skillful surgeon with you with a good backup and an infrastructure, maybe a radical procedure like a Roux-en-Y can be done, can be offered to a particularly who has got multiple conditions, obesity, BMI, more than 50 or so, right at the first go. But if the surgeon is not available, the patient does not have so many comorbid conditions, the weight loss desired is not so much, maybe a sleeve can be done, or just an intragastric balloon can be inserted. And the weight gain that happens will depend upon that also. That needs to be kept in mind. The future directions, I have already mentioned, the world is moving from laparoscopic to endoscopic procedures. One of the endoscopic procedures are the endobarrier line. You just line the duodenum and upper jejunum with a polystyrene, this tube which is there, causes malabsorption. You can do that. Research being done even in our country, maybe Dr. Harikumar can tell, I think it's being done at the Asian Institute of Gastroenterology at Hyderabad. But early days fought with complications even in the early days, but we need to be lookout on more endoscopic procedures. Of course, endoscopic sleeve, even endoscopic one anastomotic mini gastric bypass are now underway. We are going to see that. So just a word, I've already mentioned again and again, surgery is more effective and more durable than conventional treatment. You need to choose the patient, particularly those with severe obesity and those with comorbid conditions, because even they are addressed, even diabetes is remitted, and significant improvement in quality of life and enhancement of lifespan is observed. So you have a long-term data with surgical interventions, and it prolongs the life as well. Although it needs to be stressed that surgery, the last line, is associated with complications, mortality, which is finite, morbid conditions, which at a later date the patient can encounter. So just a table to summarize that there are restrictive procedures, malabsorptive procedures, depending upon the amount of restriction you do, the amount of procedure you do, the weight loss is anywhere between 40 to 80%. Remission rates of diabetes from 30 to 80%. And of course, the more radical a procedure, more radical the complications, including mortality is there. So, dear friends, bariatric procedure is the only effective long-term treatment available for morbid obesity. It has a robust long-term evidence to back it up. It is still evolving. I've already mentioned that it has moved from open to laparoscopic to endoscopic. It addresses comorbid conditions, and all of you have seen the success of the surgical treatment in most, while you are either reading a magazine of a celebrity or even on television on news. Thank you very much.
Thank you, Dr. Ajay. It was really a nice talk, informing about all the procedures, all the side effects, and labeling it as the treatment which may remain for a long time, and patient may remain thin after going surgery for once, which usually do not develop after taking oral therapy or pharmacotherapy. There's one question for you from Dr. V.K. Goel. Enumerate the critical complications of obesity. I think you have enumerated many of them.
You need to choose the patient, and you need to have a team before you can ask the patient to undergo a surgery. So finite complications of surgery, including the perioperative mortality to long-term complications of protein, vitamin, mineral malnutrition, they all are there. Commonest would be the GI side effects because of stomal or the gastric leak. We generally do a leak test on the second day of the procedure while the patient is admitted. We need to confirm that there are no leaks on second or latest by the third day. So these are one of the common, this is a common protocol at our hospital.
Ajay, will you stop sharing your screen? Yes.
Okay, I've stopped sharing.
Yes. Dr. Harikumar, are you?
Yeah.
Yes, a question for you. Any, I think, comparison of topiramate versus buspirone? Any comparison of topiramate versus buspirone?
Topiramate and buspirone, no. Bupropion is there with the
Yes.
nitroxide combination, but not buspirone. But there are no direct comparisons between the two. So that is not there. But as a general, both centrally acting, they lose about 5 to 7% of weight loss. Both of them have been approved. But generally, if you have got especially somebody with a chronic headache, somebody with an epilepsy, preferable to choose topiramate as a drug which is going to help in weight loss also. Somebody whom you are otherwise considering a treatment for migraine, even for a diabetic, even for a obese, topiramate is a better drug to choose, which will help in weight loss as a standalone agent.
Thank you. Thank you very much, Dr. Harikumar. Dr. Ajay, even if you find so many evidences for beneficial effects of the bariatric surgery, but majority of the patients initially or most of the time, they always say that we will not like to go for this procedure. What can be the reason for it? Patients are not easily convinced. They say that they have seen so many patients, they have very bad prognosis, or they do not eat, cannot eat something like that only.
So there is a social factor to it. Nobody wants to undergo a surgery. The moment you say surgery, many people will back out. So if you say laparoscopic, some will undergo, some will accept. And if you say endoscopic, most might accept because they think that the surgery has a psychological effect. Second, the social populace of bariatric surgery is not there, in the sense that celebrities, known celebrities who have undergone bariatric surgery are not declaring. So that the basic premise of choosing a celebrity to endorse or propagate is to create a mindset. So many business tycoons, celebrities have undergone bariatric surgery, not disclosing. Officially, let me put it, only 2 politicians have disclosed that they have undergone bariatric surgery. So these are some of the social factors. Availability of a surgeon and a bariatric team is another limiting factor. Cost could be another one. And sometimes patients are unwilling to follow up or not accepting the side effects. So these are some of the reasons why it is not becoming so popular with general public.
Thank you, Ajay. Yes, Dr. Harikumar. Please.
So only a couple of quick points. Actually, we had one of the largest series with the ileal interposition and sleeve gastrectomy from India. We have almost about 100 patients on follow-up, and we have published about 5-6 papers on it. And we have actually looked at pre-surgical scoring system also we devised, where the patients are likely to benefit after undergoing surgery. Like you have, as Dr. Ajay rightly said, duration of diabetes, age, BMI, complications, all those things matter. And nowadays, with the availability of GLP-1 drugs, we are actually putting most of them on a trial of 3 months GLP-1. See whether they are actually losing weight, see they are actually getting beneficial, because one of the key mechanisms of losing weight after the bariatric surgery is a boosting up of your GLP-1 level. So if you are actually losing in pharmacological way, you would actually get a potentiated benefit in a surgical way. So it is like a bridge towards surgery. Also, we are trying out in, especially in that morbidly obese ones. And as very correctly said about everybody hiding there, it is the owner of the Twitter is the only one who has put out that I am using a XYZ drug. I won't name the drug, but that is what which boosted the popularity towards it. So it is like you should not hide it. If it is good, you should say it. But people give Arun Jaitley as an example, but I mean, the another living example is what he's already shown.
Yes. So many of the people do not tell about that. The particularly celebrities, laymen will
Correct.
not like to will not hide it. And okay, with this, I will like to thank you both of you for your nice talk, and you have given very good insight on the topic. And I hope most of the audience must have got benefited. Thank you, Dr. Harikumar, Dr. Ajay Shah. And for the audience, for the participants, the certificates for this course are already ready. And in the next few days, you will get by post if you have sent your postal address on the WhatsApp group. Otherwise, they will also be available on the online. And these all talks are available on the YouTube also for your future revising the topics and seeing these lectures. Thank you very much. And very soon we will be starting new course on hypertension right from the next month. Thank you. Thank you, Dr. Harikumar. Thank you, Dr.
Thank you, sir.
Thank you,
Dr. Ajay. Thank you, sir.